All right. Well, good morning, good afternoon, good evening, wherever in the world you may be today. Thank you so much for joining us today for our second live case-based discussion in our series on complex lower extremity trauma. Today, we'll be talking about tibial plateau fractures and really appreciate the interest and enthusiasm for this topic and all the great lectures that were prepared by the faculty. So just a few housekeeping things before we get started. For Zoom, we have activated the translated captions if English is not your first language. So please feel free to follow these instructions to activate your captions. You can select your speaking language and then put the language that you want your captions to be translated into. And that will allow you to follow along the meeting more easily, hopefully. So these are the course objectives for today. So first and foremost, our number one objective is always to improve participants' knowledge of lower extremity trauma management. Second is to foster international discussion and provide practical advice for surgeons practicing specifically in resource-limited settings. And then third, to motivate and support the younger generation of surgeons globally. So my name is Kieran Agarwal-Harding. I'm the director of the Harvard Global Orthopedics Collaborative, and I'm the course chair. And I'll be handing over to Dr. Shravya Challa, who is our session moderator today. So Shravya, take it away whenever you're ready. Perhaps Shravya is having some technical difficulties, so I'll keep going for the time being. So I just want to introduce everybody from our wonderful HGOC and SONA organizing team. It's really a pleasure to work with these fantastic individuals who have contributed so much to our conference. Thank you to each and every one of you for making this conference possible. And then I'd like to introduce our case presenters, Dr. Dominic Konedu-Yeboah coming from Kumasi, Ghana, Dr. Salem Langi coming from Benghazi, Libya, and Dr. Ebsa Bekado coming from Soto Christian Hospital in Ethiopia. We have 3 cases lined up for today and maybe an extra case if we have time presented by the faculty. For case discussants today, we have Dr. Naresh Agarwal, Dr. Dwayne Anderson, Dr. Paul Appleton, Dr. Ken Rodriguez, Dr. Fasi Shahab, Dr. Dave Shearer, Dr. Carla Smith, Dr. Nishant Suneja, Dr. Mark Swankowski, Dr. Jack Wickstead, and Dr. Pierre-Marie Woolley. So they'll join us intermittently over the course of this and hopefully provide some commentary and feedback on these cases. So today's agenda, this very quick introduction by me, and then we'll hand over to Dr. Shravya to begin the moderation of the cases, starting with Dr. Salem Langi's case, followed by Dr. Dominic Konedu-Yeboah's, then Dr. Ebsa Bekado's. So without further ado, I will hand it over to Dr. Salem. Salem, whenever you're ready, please go ahead and share your slides.
Hello, everybody. Hello from Libya here to everyone everywhere in the world. Okay. Now, is it clear with you here?
Looks great, Salem. If you just make it full screen.
All right. Can you see it now?
Yes, perfect. Thank you very much.
All right. Hello, my name is Dr. Salem Langi. I'm an orthopedic consultant in Benghazi, working in Benghazi Medical Center in Libya. We face a lot of fractures, especially during conflict the past 12 or 13 years, mostly open fractures and explosive injuries and others, similar injuries. But today we'll be talking about kind of civilian injury that the usual that is actually outside this conflict zones. We talked today about tibial plateau fracture, about a lady who she's 62 years old, female. She's obese. She was complaining of osteoporosis, no treatment. She wasn't in any treatment. She fell downstairs and sustained an injury to right knee, so that's why she wasn't able to walk or to move. The fracture was closed, and she was taken to the hospital, and where they took full history and examination, and she was complaining of diabetes, esophageal reflux, irritable bowel, beside her overweight. We did the routine blood test and X-ray and CT scan. The X-rays was done, and as you can see, the AB view is here. show on examination, patient was a little bit in valgus and pain, of course. And the X-rays, the AB shows Chaska type 5 fractures, bicondylar fractures, comminuted fractures. As I said, it was closed and swelling on examination as well. There was no any definitive neurovascular status, and that's the X-rays that we got. Well, we went further and we did a CT scan. These CT scans show the sagittal views for the tibial plateau. Can you see the fractures going through anterior posterior as well? It's very comminuted fracture. Regards her bone quality, very poor. And you can see very obvious here, there's displacement, depression, comminution on the coronal views, bicondylar fractures. On axial views, you can see the all bits and pieces of the tibial plateau from all the sides, anterior, posterior, lateral, medial condyles, all comminuted. This is the close-up for the coronal views, show you the magnitude of injury and damage that happens to the articular surface, to the tibial plateau, all the depression happening to the tibial spine as well. We did all the routine blood tests and chest X-rays and prepared the patient for surgery. We went and we did lateral skin incision or approach. We cleared up. The bone was very difficult to manage, and because of the comminution, we tried to put it together with the plan in mind that she would need at some stage in future total knee replacement. That was explained to the patient before we went to the surgery. In Libya, one of the problems we have with either you can take bone graft autologous or you can, there's no substitute, there's no synthetic bone substitutes. So this is one of the difficulties, and because there's no like certain depression as such, they would need, we didn't think that you might need bone graft. This is the X-ray post-operatively the following day. And you can see the articular surface was not, because of the comminution, we tried to do our best to restore the contour for the joint. This is this patient. This X-ray was done a couple of months after that. Patient was came to the after serial follow-ups. Patient was complaining of moderate pain on weight bearing 6 months later. She was walking with walking aid. Of course, she lost a little bit of weight, but not much, to be honest with you. And she wasn't compliant with the physiotherapy. She doesn't, and X-ray shows malunion. You can see the posterior, the proximal bit is going to the space posteriorly. And this was depression on the lateral side, on the lateral view, with a bit of fragments is away. And so we decided to remove the plate, and that was it. After removal, looked disastrous, to be honest with you. But as I say, the plan was explained to the patient from the beginning that she would be heading towards total knee replacement. And still, she didn't go to for treatment for osteoporosis. Even I was sent her, she didn't take any treatment or medication for osteoporosis. And so now the plan is when we took the plate and hardwares, patients felt a little bit better, but still complaining of pain. And what's the future plan now? Is total knee replacement, or she would need kind of a revision to the clinical documentation for lateral side or bone suck. And just to be clear, we don't have bone banks in Libya at all. Like any city in Libya, we don't have any hospital, don't have any bone bank. The other thing, the cost effective, the cost of the substitute is a bit high, so we're not using it. we're not using because it might cause more than 7,000-8,000 Libyan dinar, which is too much and too expensive to patients. And that's it.
Good morning, everyone. I'm Stravia. I'm one of the orthopedic fellows here. Just here to moderate the discussion. Thank you so much for presenting this case. Clearly a very complicated case, and in a patient with osteoporosis, very difficult to manage these fractures. I know Dr. Appleton's online, wondering if you have any comments on this case or the difficulty of managing these injuries in osteoporotic patients, and more specifically commenting on if you see a bicondylar plateau fracture, are you thinking 1 or 2 implants, and how you go about that?
Thanks, Shravya. I mean, these are hard fractures, especially in the osteoporotics. We see a lot of these, and we used to do single plating a lot of the time, but I think now we've kind of shifted, if you have the plates, to try to do a dual approach, because this is sort of a classic thing that happens a lot. The other difficult situation is not having any bone substitute to put in there. We're lucky that we have like calcium phosphate cement and bone chips, but I think that's, I think you did a great job. It's a difficult case for sure, and very hard to manage these, especially in the osteoporotic, which seems to be a big part of our practice.
Alan, could I ask you to put your slide back up with the x-rays, just so that we can use those as a discussion?
Okay.
And can you comment a little bit on your choice of using dual plates versus a single plate, and why you went for lateral only in this case?
Are you asking me?
Yeah, yes. I'm asking you, Salim. Yeah.
I'm used to this approach, to the lateral approach. I don't usually prefer a second approach, a dual approach, because I think because of the soft tissue stripping that you might get from doing to dual approach for this patient, and the risk of infection would be higher with 2 incisions than 1 incision, especially for patients with diabetes and with obesity. So I try to minimize this the number of approaches. And I usually, patients like this, even if you do dual approach, I wouldn't think you get proper reduction, So I'm just afraid of the soft tissue coverage and the swelling for the patient there, and the fat is there, and the high risk of infection. And this is that stopped me from doing dual incision. And I'm thinking about even in the future, I might do total knee replacement. So if you have a scar on one side and one in the middle is fine, it's better than have 2 scars and one in the middle.
I think those are all really important considerations you bring up. On the chat here, people have started asking a little bit about, if you don't have allograft bone, what potential options do you have for autograft here, whether it's iliac crest or elsewhere from the tibia? Is that something you considered? Is that something you guys routinely do?
Do you think will it help in this case?
I think that having some kind of support to prevent the collapse may have helped, but I mean, it's obviously a very difficult fracture, Salim. As you've pointed out, and as Paul just mentioned, I think that there was a comment here also about whether it's too smashed and maybe you should just go for an acute total knee. But I'm a student really of Paul, Ken Rodriguez, and Jack Wickstead, who are on the line, who taught me that really the idea here is to build a foundation, even if the joint is bad, because then eventually you can do a much simpler total knee rather than having to just remove all of that smashed bone. You just build back up a foundation upon which you can then create a total knee replacement with more simple components. I don't know if the other faculty have comments on that, but the comment about bone graft, I think like you were trying to bring up the joint surface and then backfill. I wonder, I mean, if you don't have allograft, here we frequently use allograft cancellous bone chips. but perhaps using cement to fill that void, other methods of filling that void to prevent that collapse. Just curious what others would comment on that.
Can I interrupt you here 1 second? Actually, we have a little limitation here in getting knees like there. So if in case I need to do acute total knee replacement and I use to and I have to use a revision kit, a stem with a stem tibial component of the stem is not available in Benghazi. You have to order it from Tripoli. And because they're doing some revision there into the knee, so I have to wait for 3 or 4 days, or maybe up to a week, to get it over from Tripoli, which is 1,000 kilometers away from us, and they have to come by plane or by car, which is 9 hours. So it's not feasible to do. It is not available on shelf. You have to order it before that. By this time, the patient will have no patient wait for you, so might go somewhere else, or to decide to travel abroad. We have kind of a tradition here. A lot of people, they travel to Tunisia or after surgery or before surgery or whatever, like, they want to perform their surgery there, because sometimes in the hospitals there, everything is available at one center. But for us to have to prepare for that, to have to send for set from Tripoli, and this, even it's one country, but still hard to get it in the same day or second day. So you have to wait for 5-7 days.
Yeah, no, I think those are
It's quite expensive as well. If you use a revision, it's about 8,000 euros. And
Yeah.
you talk 8,000 euros, you time it by 6, will be like the amount of money that Libyans have to pay just for the prosthesis.
I think that an acute knee perhaps is the wrong choice in this case for many reasons, not only the ones that you've listed. But Dr. Dankwart Hunch is on the line and has raised his hand. Dankwart, did you have a comment that you wanted to make?
My English is not so well, therefore please accept it that I speak very slow and it's difficult. Also, I recommend to use autologous bone grafting. It's a low-tech method, and you can get a lot of bone in the iliac crest on the similar side. And this in my eyes, is more or less a good recommendation. The second is, this might be a good case, even in countries like yours, that you use ring fixator methods. Also, for example, a hybrid method, a ring for the tibia head and unilateral on the tibia. You can stay a long time with them and make exercises and so on. But for that, you need a bone grafting. And perhaps one plate, you can also mix it, a plate and a ring fixator, also for the tibia head. When you think, also when I am in your country or in similar countries, I would like to prefer this. And once more, bone grafting is, I know it worldwide, it is unusual because it's another operation on the iliac crest, but I'm an old boy, a long time there was no bone grafting or banks available or substitutes, and this bone grafting, you can harvest a lot of bone grafting in the iliac crest. Thank you to hear to my recommendation.
Thanks, Dankwart. Great points.
Dr. Wickstead, it seems like you have a comment.
These are really challenging cases, particularly when the comminution extends right up to the joint line. One of the limitations that you run into with circular frame fixation is that the skinny wires can't go within 1.5 centimeters, 2 centimeters of the joint line, or the joint can get infected. So this would be a challenging one to use a frame on. The benefit of the frame, of course, is that you get to maintain length. And I think if you look at your first post-op film, this is already starting to collapse a little bit. I don't know if you have access to, the formal fancy femoral distractor, but for a situation like this, a femoral distractor can be very helpful to get as much possible length as you can on, right at the beginning. And if you don't have a femoral distractor, then using even an external fixator that you put on temporarily just to maintain length can be very helpful for this. Is this a locking plate? Do you have locking screws in there? Is that what that is?
IS locking plate, yeah.
Yeah. So, I think the locking plates can be very helpful for maintaining your axial alignment here. But again, maintaining, that length right at the beginning can be very helpful for that. I would be a little careful about, running your locking screws out to the medial side on the far side of the bone. Generally, the medial plateau has pretty good bone, and you can stop the screw short of the cortex. And then patients will have a lot less medial irritation. But my only comment here would be to try and maintain as much length as you can right from the beginning by using a distractor or an external fixator to gain length when you're doing the case.
How long are you planning to put the external fixator before you go to definitive treatment?
Well,
Yes.
you can use it when you're in surgery. So if you have the distractor, you can dial in the length. But even if you don't have a distractor, you can put an external fixator on the patient and pull like crazy. Then put the external fixator on, get your overall axial alignment, and then work around the external fixator, put the plate on, maintain that length with the locking plate, and then take the external fixator off. Or, alternatively, you can leave them in an external fixator just for a couple of weeks. Yes, we want to get early range of motion on these patients, but sometimes maintaining the alignment, at the expense of early motion can also be helpful. So just, some tricks you might want to think of.
One of the challenges that I face in this surgery is the amount of fat around the soft tissue. It's very hard to maintain reduction in the
Yes.
and the quality of the
Super
bone.
hard. Yeah, when the whole thing is flopping around and you have a very fat leg, it's really difficult to keep that length because every time you pull on the foot, it just slides away from you. So in that case, putting just a simple 2 pins into the femur directly anterior even, and 2 pins into the medial tibia below where you're going to put your plate, also directly medial, and pulling like crazy on it and using just a couple simple bars to hold that length and alignment for you. That gives you access to both the medial and lateral sides if your frame is anterior based, and then you can take that frame off. And if the fracture is terrible, you can or for those of you who do not have access to locking plates, leaving them in a frame just for a couple of weeks to try and maintain that length can be helpful. In this case, you've done a nice job with this, and you have the benefit of locking plates, which helps you in terms of not needing both medial and lateral approaches. For those of you in the audience who don't have locking plates, this will collapse almost right away if you don't have some supplemental, frame on there to hold it out to length for at least a couple of weeks. So, as long as you keep your X-Fix pins away from your plate, you can use, those. In this situation as well, most of the fracture is really proximal, so you don't need a very long plate, and you can use the external fixator just as a supplemental, short term, just to maintain length.
Thank you, Dr. Wigstead. Something that's come up a lot in the chat and also in the discussion already is the role of primary or staged arthroplasty for these fractures. Can the faculty comment on the difficulty of using that in these fractures or when that might be appropriate?
I mean, I could defer to somebody else on this. I wouldn't use a primary arthroplasty here because you really need a proximal tibial replacement, right? It's so common that you would almost need a tumor type prosthesis and a hinge. And that's going to be A, expensive, B, complicated, and C, fraught with infection. If this goes bad, we've got some options, right? If your hinged total knee prosthesis goes bad, you're looking at an amputation. So I would steer, most people away from this, except under extremely odd circumstances.
In a resource limited environment, and I practiced 20 years in Ethiopia, this would be an extremely daunting patient with diabetes and obesity. And we used to have a bolt. So it would be a thin little, like 3 millimeter, fully threaded screw. And then you could tighten it on both ends. And the way I would treat this patient, fortunately, we don't see these severe osteoporotic fractures in Ethiopia, but what I would do is put this patient in ankle traction and see what kind of x-ray I get, improvement of it. And then I would try to do a minimal lateral approach in this case and try to improve the alignment, and then pull the condyles together with probably 2 of those little bolts. That way you don't have to trust the opposite cortex to hold your fixation, and then keep her in traction for 3 weeks. So a minimal approach, minimal internal fixation, traction 2 finger breadths or 3 finger breadths above the ankle, and start range of motion on post-op day 3. In my experience, that minimal approach allows several things. It allows you to start immediate motion because in traction, the patient does not have any joint reaction forces. You've limited the soft tissue dissection, so your potential for soft tissue healing and infection is smaller. And the soft tissue and bony healing progresses more rapidly. And then you have a very little operation to take out the hard work in preparation for a total knee. That's the way I would approach it.
Thank you. Dr. Agarwal, do you have a comment?
It is a challenging case in any circumstances. Of course, the type of treatment will depend on the facilities available and the expertise and experience of the surgeon. In my circumstances, I would almost agree with Dr. Dwayne. I would put straight away this patient on skeletal traction, heavy skeletal traction, or as much as tolerated, and then start immediate mobilization without any fixation on day 1. And then maybe repeat a CT scan after 10 to 15 days, depending on maybe a portable X-ray will guide me when to repeat a CT scan once. And that will definitely, I have been doing this in many circumstances. Now, these are the fractures which in my practice select themselves out of any major surgery, like which involves soft tissue stripping or going after the bone fragments. They have selected themselves out of those fractures. So once the fragments fall in place, and they are very likely to fall in place after traction, I would do minimal internal fixation. First, the percutaneous screw with the major fragments, and depending on the CT scan, their direction will be guided. And then put maybe a couple of cross wires from both the condyles at the ends into the shaft of tibia, 2.5 to 3 mm thick K wires, and then continue with mobilization. And we've had very good results with the conservative approach. And that is what I would do. Avoid any soft tissue stripping surgery. Avoid going after the fragments because it's not possible to do. We are likely to do more damage than good. And that would be my approach in my circumstances.
Thank you so much. It seems like, when you kind of recognize the limitations of what you're able to achieve with such a comminuted fracture, more and more the faculty think there's a role for limited fixation, range of motion, and then plan for a later surgery. Dr. Swantowski, your comment on the chat about similarly doing so and potentially using casting was very interesting. Do you want to make any final comments about this case before we move on?
No, I would just a limited period of casting, perhaps only 10 days, and then early motion. And I agree with the prior 2 speakers, absolutely, that limited surgery is probably best. I don't think you would need a hinged knee for this. It would be a stem component that would be rather long and a very thick polyethylene tibial component, but it wouldn't need to be a hinge. But in this resource limited situation, I'm not sure that would be available. But anyway, I would definitely agree with the last two speakers, and some form of limited exposure and or conservative care, followed
Yeah.
by knee replacement if possible.
Yeah, I don't think you would need a hinge if you were to let it sit for a few months and let it, consolidate. It would probably consolidate short, and you wouldn't need a hinge. But if you tried to do this acutely on day one, you'd probably run into some troubles.
I think that's a very important point about trying to address this day one with an arthroplasty versus letting it consolidate and do it in a delayed fashion. Dr. Salam, do you have any final comments about the case? And then if not, we'll get to the next case.
No, just having look at this is now the patient as at the moment like this, her knees. What kind of total knee would you put? Will you put with total knee with the stem, like a revision knee? I don't think with augmentation the lateral side, lateral tibial.
Well, I mean, I think at this point, Dr. Swinkowski's point is perfect. You just use a standard stemmed tibia. It doesn't have to be terribly complicated, right? So, a stem tibia here should do fine for you.
Okay, thank you very much.
Thank you so much, and thanks again for presenting the case. We'll go to the second case.
Thank you very much.
Thank you, Salam. Excellent, very, very challenging, and you did a great job with what you had. And I think it's fantastic teaching for all of us. Thank you so much for sharing.
Thank you. Now you have to excuse me. I have surgery to do.
Please, we all understand. Yeah.
Thanks a million. Thank you.
Thank you. So now I'll hand over the microphone to Dr. Dominic Conedo-Yaboa. Dominic, if you're on the line, please share your slides and you can go ahead and get started. Thanks to all the faculty for those great comments. Really excellent discussion.
Hello, I'm Dominic Conedo-Yaboa. On behalf of the team that managed this case, I make this presentation from the Konfanochi Teaching Hospital in Kumasi, Ghana. Our case is entitled Tibial Plateau Fracture Management in a patient with uncontrolled diabetes. So the learning objectives of my presentation are to appreciate the challenges of management of severe tibial plateau fractures in uncontrolled diabetes in the developing world, to demonstrate the risk factors for skin breakdown in the management of these cases, and to outline the treatment methods and outcomes. So our case involved a 64-year-old woman who presented with painful left leg of 2 days duration after a slip and fall from a standing height over a gutter. The patient was a known hypertensive and diabetic, which was poorly controlled. So at the time of admission to the hospital, his fasting blood sugar level was high as 11 millimole per liter. The physical exam of this patient revealed a swollen left leg with multiple blisters around the proximal leg. The dorsalis pedis pulsus, the neurovascular exam was normal. There was no feature of acute compartment syndrome. A radiograph that was taken showed a Sachs 6 tibial plateau fracture. As you can see, the quality of the X-ray is suboptimal as we don't have the lateral view of the knee, but you can see a lateral split of the lateral plateau with anterolateral comminution and depression and dissociation of the metaphysis from the shaft of the tibia. So following the principle of span, scan, and fix, we temporize with a knee bridging external fixator, as you can see, obtain a CT scan before we undertook the fixation. The CT scan showed both coronal and axial cuts, coronal and sagittal cuts, and it revealed further details about the comminution and depression of the anterolateral and the posterolateral plateau. The 3D reconstruction equally provides details about the comminution of the fracture, and that included a fracture of the head of the fibula as well. And this patient, I must say, did not have a foot drop, and in other words, we didn't have evidence of common peroneal nerve palsy. So what did we do? The patient hemoglobin level was very low, so we corrected the anemia. The deranged blood glucose level was corrected, and then we performed fixation with a locked bicolumnar buttress plate 14 days after the injury, when the swelling and blistering had resolved. So we used the anterolateral and posteromedial approaches to the proximal tibia. So this was the fixation we achieved following the surgery. And I must say that we use rafting screws to support the elevated plateau. It has been discussed equally. We use a lock plate combined with the rafting screws, and so we did not go ahead to apply a bone graft. Probably we could have if we had it available as well. So the patient was discharged home with a clean and dry surgical site. But we saw him again 8 weeks following the surgery with exposed medial plate. As you can see, there were 2 patches of skin breakdown showing the plate. And indeed, this was a confirmatory criterion for a fracture-related infection, FRI. So what did you do? The principles of managing this patient, we thought would be first to optimize him, perform adequate debridement, obtain viable soft tissue coverage, and then continue her on biofilm active antibiotics. So this was the initial washout, where you wash the wound copiously with tap water and a tinge of chlorhexidine initially, and then followed it up with normal saline irrigation. So this was the appearance of the wound soon after the irrigation. So the next plan was to raise a flap to cover the exposed bone. So we raised the medial head of the gastrocnemius, tunnel it under the skin to cover the plates, as you can see on the left-hand side. On your right-hand side, you can see the flap 7 days after the surgery, and it had survived. So what we did next was to harvest the split thickness skin to cover the wound and to continue the patient on biofilm active antibiotics, rifampicin, and quinolone ciprofloxacin via the intravenous route. So we continue the patient on the antibiotics to make sure that we don't have a recurrent infection. So the message to take home from my presentation is that complication rates could be high in the elderly with severe tibial plateau fractures, and skin breakdown may occur post-fixation of these fractures, and achieving glycemic control before and after surgery, correcting any anemia that may exist, could improve the outcomes of this patient. Thank you for your kind attention.
Thank you so much, Dominic.
You mind going back to your preoperative x-rays just for the purpose of the discussion? Sorry, Shravya, go ahead. It's all yours.
Thank you so much for presenting this case. I think it's an excellent result you've gotten in a complicated patient that had wound dehiscence. There are obviously lots of things we can discuss in this case. One of the things that I wanted to put out there for the faculty to comment is, when do you retain hardware in these cases and when do you not, when you see a wound dehiscence like this? Dr. Sinead Rodriguez, do you want to comment?
Yes, I was trying to unmute myself. Hi, Sravia. How are you? Good morning, everyone. Such a pleasure to be here this morning. That's such a tough question, Sravia. Thank you for asking again. And it puts us always in the spot because it's hard to tell, to give you a series of rules or criteria. Obviously, if it's I usually decide based on how dramatic the infection is, right? And how involved the whole length of the instrument is. But also, keep in mind what one of my mentors told me once, that the only thing worse than infected implant, right? It's an unstable infected fracture. So some degree of stability is still required to be able to resolve the infection, because otherwise things could potentially collapse. So in a case like this, I would be very supportive of maintaining the medial hardware, right? And then do what I can to preserve it. Now you can exchange the hardware and do your debridement and put some new hardware in there that you could decide at the time. But I think you have to make this choice between stability and the cost of not having the hardware there.
Thank you so much. Dr. Smentowski, you have a comment.
I agree with this speaker's comment exactly. And if the implant is providing stability and it's fairly early on, there hasn't been attempts at dressing changes for 3, 4, 5 weeks, then leave it in place. And I think the treatment decision in this case was absolutely perfect to get it covered early when there's a wound problem. The one additional comment I would make is the medial incision probably could have been, another 3-4 centimeters posteriorly, and perhaps the medial plate applied more posteriorly, and that may have avoided this skin bridge dehiscence.
Thank you. Dr. Wickstead?
Yeah, this is a really nice case. It illustrates a lot of good points, and I agree. The management of this in terms of early coverage was super, right? In this case, you can't really take out that medial plate because you need it for stability. So my sort of take on can you remove the plate is, how important is the plate? I would make just a brief comment that, I don't know how many golfers there are here. I'm not a golfer myself, but you can two putt on this. You can do this in stages, and if you're going to do dual plating, you don't have to do both your plates at the same time. Sometimes it can be helpful to put the medial plate on early at the time that you're putting the external fixator on. If the soft tissues will allow it, it facilitates your external fixator and it makes things a little bit easier to maintain your alignment. And then you can get the medial side to heal up and come back and fight the lateral side, 2 weeks later. And sometimes staging out your wounds is a good strategy for minimizing your wound complications, particularly in patients with diabetes.
I think that's a great point. Dr. Ibsu? All right, we'll move on to maybe, okay, there we go.
Okay, it was a nice presentation, and is there a known cut point for diabetic patients to proceed with fixation like plating that we saw in the second case? I mean, the fasting blood sugar was so high. Plus, do we need to follow the fasting blood sugar or hemoglobin A1C to decide whether we are going to operate or manage them conservatively or minimally or with invasive surgeries like using plates?
I mean, I could make a stab at this one, Saravia. There's there's some recent data by Zach working out of Oregon that looked at whether or not the complication rates from surgery was related to how bad somebody's hemoglobin A1C was. So they looked at, complication rates related to patients with low versus high hemoglobin A1C, and they all had high complication rates. So the sort of point was, if you have an elevated hemoglobin A1C, that's going to be problematic. And whether it's 7.5 or 10 or, 11 is probably irrelevant. Now, I think when you get up into the super high hemoglobin A1Cs, 12, 13, in patients who've clearly had many, many years of neglected or undiagnosed diabetes. That's probably a different situation. But for the most part, whether you have a hemoglobin A1C of 7.5 or 10.5 is probably irrelevant. And I would focus on getting good glycemic control going forward. And I wouldn't, try and delay somebody's surgery 2 or 3 months while you get their hemoglobin A1C from, 9 back down to 7. I'm not sure if any of the other faculty have, similar.
I see Fossey has his hand up. Fossey, did you have a comment?
Yes, I have a comment. It's an interesting case. 2 points. One regarding the question of retaining the hardware. So it's multifactorial, and you don't have like this and that for it. And in the case, if the plate is holding the fracture and the fracture is stabilized and the infection is going down with the use of antibiotics, so I would tend to retain the hardware as long as I could. So that there can be some bone union, because the worst part, as mentioned by the earlier speaker, is a non-union with an unstable bone. Secondly, although I cannot see the fracture clearly, but if it's just like the anterolateral aspect of the tibial plateau is concerned, I would be tempted, as is in the pre-course videos by Dr. Agarwal, to put the patient in ankle traction as Dr. Duane advocates, and then put in an intramedullary nail to fix the proximal tibia in this case, considering the obesity, considering the poor glycemic control. So for me, that would be one option of treating this patient initially instead of putting plates.
Thank you, Fossey. Something that's sort of come up in the chat and discussion so far is this concept of where the incisions have been next to each other. Are there any rules that we follow about where we can put incisions when we're dual plating a plateau? And do the faculty have any comments on how much you follow those rules, if there are any?
I think I saw Nishant's hand up. Nishant, did you want to talk about it?
Absolutely. Good morning, everyone. Very challenging case. I'll just comment. I think it was well done in terms of getting it covered with the flap. In questions about rules of keeping the distances as far apart, I know there have been rules in the past about 7 centimeters, and then I have been recovered saying that that's not required. But the general rule I follow is trying to keep them as far as possible. Like in this case, trying to make the incision slightly more posteromedial and trying to keep it far away from the anterolateral incision might have been helpful. But I do see that the implant was a list plate, which you really can't put it more posterior. You have to put it straight medial where the surgeon did. So I think that was a good place to put it. My one support was that I personally, when I looked at it, I thought, given the uncontrolled diabetes, fixing it medially first and then waiting a little bit and then making a lateral base incision like 2 weeks after, that can sometimes help me personally if I'm trying to avoid wound dehiscence problems or lowering my infections.
Thanks, Nishant. Dr. Anderson, you have a comment?
Yeah, I think the other thing is one of the risk factors for postoperative infection is a spanning X-fix. So diabetes, spanning X-fix, and dual plating are all additive, in my opinion.
Dr. Wickstead?
Yeah, just, to get away from the infection issue, I would also, can the presenter go forward a slide to the post-op films? Just a brief comment. For those, when you have an X-ray, this makes it a little bit easier, right? You can use the Bovie cord to check your alignment by, scanning from the hip to the knee to the ankle, which should all be collinear with the Bovie cord. If your X-ray is not available to you, you can still, just look at the patient overall. And I would suggest, if you don't have a Bovie cord, to prep the leg higher so you can get an overall look at the patient. And before you put your second plate on, you put your first plate on and you want to make sure your axial alignment is correct. Just step back and stand at the bottom of the table and take a look at the leg and see whether or not it lines up correctly, because your eyeball is pretty accurate, and you'll tell whether or not the patient's in valgus. In this situation, good outcome for this patient with the flap coverage, but we're in probably 10 or 15 degrees of valgus, which is going to really overload that poor lateral side down the road. So if you skip forward to the next view, you'll see that, next slide. You'll see that valgus, and if you prep up high enough so that you're, prepped up to the mid thigh or even a little bit higher, then you can, even without a C-arm, you can look at your axial alignment and make sure that your, ankle, knee, and hip are all collinear.
I think that's a really important point, Dr. Wickstead. And we've talked about how this is this fracture got dual implants. Are there principles about which plate you do first and how you address a bicolumnar plateau injury in this sense? Maybe Dr. Hunch or Dr. Wickstead can comment.
I add to John, a step further is to drape both legs. It makes it much more easier to recognize the valgus. But this is to drape it high enough is very important to have no valgus.
Jack, you wanted to comment on?
Yeah, I mean, I think, you can look at it and see. As far as which plate to put on first, I don't think it really makes any difference. I think the hard part is, we're dealing with these complicated, difficult fractures. And, I'll get a plate on something and then I'll talk myself into thinking that it's good enough. And sometimes it's hard to walk back to the crossroads and take out your screws and start over again. One of my partners is fond of saying these are algebra problems. There's only one correct solution. And if you have the wrong solution at the bottom of the page, you have to rip up the page and start over again. And sometimes in these situations, you have to recognize that you have some valgus and you have to unscrew the plate and, put it back on with a straighter leg. And that's tough, right? It's hard to admit to yourself sometimes. So just be careful about convincing yourself that your films are better. If you prep up higher and you just stand at the bottom of the table and you look upwards at the patient from the bottom of the table, you can get a sense of, how close am I to where I really belong.
It's a great point.
Dr. Jankowski, and then Dr. Rodriguez.
Yeah, just a comment about the sequencing in general for these Schatzker 5 and 6. The medial fragment is bigger and has a more distal extent. So in general, a posteromedial plate with a shorter plate buttressing the medial side is the best first step. And then with an anterolateral incision exposing the joint and elevating the lateral side with a lock plate. That in general, that's the appropriate sequence.
Okay, Rod?
Oh, I entirely agree with the sequence Dr. Jankowski just described. So I go to these cases very much with the philosophy that Jack Wickstead kind of imparted on me. And is you don't have to do everything at the same time, right? So and the soft tissues are usually very compromised. So I ask myself, if I can only do one thing today, assuming I can't do anything else later on because something goes bad, what would you do? What will give you the most value and positive outcome for one plate? And in this case, obviously, it's a medial plate because it's what's going to buttress and help you support some of the alignment. So that's the one I would do first. And then I wash my wound and I potentially even close it or partially approximate it, and I reassess at that time, are the soft tissues going to allow me to do a lateral plate right now? And if they do, I would do it. And if not, I will wait a few days, and you never know what can happen in those few days. Maybe my medial wound gets infected, and then you have to reassess from there. So always do what you think is going to give you the most first, the better outcome for if you were just to do that thing first. That's a little rule.
That's a great rule to have. There's a question in the chat about could you address this with a midline anterior incision and plate both sides of the plateau through that? I know I've done a case like this with Dr. Appleton, so I'm going to ask if he can comment on that.
I think Paul may have run off to the OR.
Got it. Any of the other faculty have thoughts about whether you can do that, or is that a terrible idea?
Well, I'll tell you.
Rob, so go ahead, Kara. Go ahead.
No, I was going to say I'm more inclined to do two separate incisions.
Yes.
But then I have to take the phone call from the knee replacement doctor yelling at me for not doing a midline incision when the patient goes to get a knee replacement maybe later on. So I think we used to do few years back a lot of these medial incisions, but you have to plan how much access you can have medially and laterally for what you need to do. And it is quite possible that if you were to do a midline incision, because most of the medial work is going to be actually posterior medial work, you're really going to be doing a significant amount of circumferential stripping that may not be in the best interest of the soft tissue. So you have to, that's the value of the CT, to look at where the apex of these fractures are, so you can kind of look ahead of time and plan where does your plate have to be, and then use that information to determine your approach.
I would agree with Dr. Rodriguez on this. I think I would steer people away from a midline incision because you don't have good soft tissue options. And this case illustrates that very nicely. You have medial plate breakdown here, and a medial gastroc flap is a great salvage for this, and it's not technically involved. There's good access online for how to do it if you're unfamiliar with it. And it's quite a forgiving procedure, and it really solves this problem nicely. But trying to swing a medial across the front of the tibia is very challenging. Trying to dual medial and lateral free gastroc flaps is quite challenging. A lateral gastroc flap itself puts the perineal nerve at risk. So, my inclination would be to do 2 incisions judiciously. That medial incision is really just a prop, right? You're just using that to strut the medial side back out to length. So you don't need the whole thing wide open. You can do that with a little incision up at the joint line and a second incision down below to put the screws in, as it looks like was done here. And that's a way to help you out. But I would steer away from long extensile medial incisions, or midline incisions.
Dominic, do you have any final comments or questions about this case that you would like to discuss with the faculty that hasn't been brought up yet?
I have one last comment for Dominic, if he doesn't mind. How's the patient doing now? Is there any sign of infection after you've done the flap?
The patient is doing well now. We are monitoring for any discharges from the site, but so far it's clean. The site has been clean and dry. So you continue here on the IV antibiotics and then monitor for recurrence of discharge.
And how's her function?
Sorry.
Function.
They have started a range of motion exercises of the knee. The blood sugar has now been controlled, and we've been able to maintain it within normal limits. So generally, she has improved. She mobilizes non-weight bearing with a pair of auxiliary crutches. And she's generally doing well.
That's great, Dominic. Just a couple comments in the chat about, can you show the last slide with the final flap and skin graft, and what antibiotics did you do, and how long, and which ones for which durations? I think that would be helpful for the folks on the call who maybe have seen similar things.
Hello, Karan, can you come with a question again?
Just the types of antibiotics and the duration of them.
Yes, so in such a case, we have diagnosed a fracture-related infection. And once the plate is exposed, you have to assume that there has been formation of biofilm. So the antibiotic you administer must be active against biofilm formation. So usually rifampicin has been shown to have good activity in such a case, as well as the quinolones. So we, as I mentioned, even ciprofloxacin and rifampicin, which have been shown to work quite well in these scenarios. And yes, you're going to give the antibiotic for a total of at least 4 weeks. given the fact that the plate lay exposed for about 2 weeks before she got back to us.
Thank you, Dominic. Excellent case, fantastic discussion. Shravya, I'll let you take it away with Dr. Ebsa. Ebsa, if you're ready, maybe you could share your slides and we can move on to the third case.
That's great. As Dr. Ebsa is pulling up his slides, I think Dr. Agarwal had a comment to make still.
Quick question. Did he add some local antibiotic delivery mechanism or something before doing the flap or at the time of putting the flap? I think that was a very good decision to put the flap, but did you have some local antibiotic delivery system or, antibiotic cement or maybe biodegradable things or maybe simple antibiotic powder, just sprinkle inside the wound? Did you do something there for local antibiotic delivery?
Well, no, it's something I usually don't do due to induction of resistant strains is discouraged in most of our practice. I know some surgeons do, but I usually do not introduce local antibiotics at the site. So for this one, we relied on the completeness of the irrigation and the debridement. And yes, in situations where we think that there hasn't been sufficient elimination of the contamination, then we could go ahead and then introduce antibiotics locally. But this one, we didn't think that there existed a need.
Okay. Thank you.
Thank you, sir.
Thank you. Dr. Ebsa, you can do your presentation now. Dr. Ebsa, are you muted by any chance?
Can you hear me now?
Yes.
Yes, thank you.
Yeah, so this is Ibsa from Sodo, Ethiopia. I'm a 5th-year orthopedics resident from PACS program. So it's a great pleasure and honor to present this case in front of you all. And I want to say Happy International Women's Day for the women out there. So I'm going to present neglected bicondylar tibial plateau fracture, which was managed with limited fixation. So this was a patient, a young male, fit patient. He's 25, and he sustained road traffic accident while driving a motorcycle. He fell over and he had tibial plateau fracture, which is bicondylar, and he was admitted in a government hospital for 5 days, and he was splinted. Then he developed gross swelling and blisters around the proximal leg extending to the mid shaft of the leg. Then he self-discharged and appeared to our setup. So on X-ray, as you can see, there is a very comminuted fracture of the tibial plateau involving the medial and lateral condyle. And it seems most of the comminution is on the lateral and posterior aspect of the tibial plateau. So he was admitted. Then after the soft tissue envelope allowed us to proceed with surgical management, we took him to the OR. But immediately when he presented to us, we X-rayed him, then we put him on distal tibial traction, and we put a traction weight 1/10 of his weight. Then he was taken, and medial and lateral minimal approach was done, and we tried to fix him with percutaneous screws using 6-5 partially threaded screws and some fully threaded screws, firing from the lateral to the medial aspect. After a reduction is maintained with minimal approach from the lateral and the medial side, and which was guided by fluoroscopy. And we also had one screw which is fired from anterior to posterior, and some two K-wires were used to just keep some small fragments so that we can attain articular reduction. Then this is like post-op day 13. As you can see, it's much more better, and it seems the articular surface is well aligned. And this is 3 years after the initial operation was done, and he has a knee range of motion from 0, 120 degrees. And so we usually treat these patients with minimal fixation, with minimal approach from the medial and lateral aspect, or from one of the two, based on the fracture pattern. Then the skeletal traction will continue till 3 weeks, and the patient is initiated on knee range of motion, usually to 30 degree of flexion with the traction just by the bedside, and usually they are discharged with the traction pin, and they are instructed how to do the physiotherapy with the traction in place. Then after 3 weeks, we remove the traction pin and we put them in medial and lateral splint. Usually, if they have a multiligamentous injury, or if you are afraid that the metaphysis and the diaphysis will have valgus or varus collapse, then you will put them on medial and lateral splint. Then you tell them just to continue the physiotherapy intermittently by removing the splints. So these patients are not weight bearing for at least 3 months. Then after, based on the adequacy of the callus formation and the range of motion that they attain, then you progressively let them to bear weight. So this guy was managed the same way, and I have called him to send me some pictures and videos, but he was playing football, so he couldn't send me the picture and the videos. So thank you.
Thank you so much. This is such an interesting case, and it seems like the patient did really well. Dr. Anderson, do you have any comments about this case before we open it up to the other faculty?
Well, this is a system that I kind of came upon after trying plating, dual plating, external fixators, and I found that in Ethiopia, the complication rate was too high with plating. And in a resource limited environment, if you have a complication like Dominic had, it's financially disastrous for the patient, and you can never get a great result. And so I think you have to try to use what you can in resource limited environments. And I finally came up with ankle traction as a way of stabilizing the patient. At one point, I was doing limited internal fixation and X fixes, and I ran out of X fixes. And also, my patient said, "Well, how can I move my knee with an external fixator? There's metal coming out of my leg." And so I kind of came upon this, and this is basically our go-to method of treating these patients. It's low tech. Obviously, you need a C-arm, but it allows rapid soft tissue healing. You start range of motion in their bed on day 3, and I've had patients in a 5-bed ward, 5 of them, trying to outdo each other in terms of the range of motion. So it does work. I'm putting together 30 patients, some of which were plated and some of which were treated with this method, and I haven't finalized the report, but my impression is that for the most part, these patients do better.
This is amazing to see. Is there a role for combining this with an intramedullary nail, or is that a no-no in articular fractures? Either Dr. Anderson or any of the other faculty want to comment?
I saw, I forgot our Indian doctor's first name. Is it Naresh?
That's right.
his PowerPoint video last night, and I was impressed with it. And I think that there is definitely a role for that. And I think that we will consider doing that in some of these patients as well. I think that that's a good way to do it. I think you have to choose your patients carefully with that. Because I think if you need to do articular reductions, you may have multiple incisions in addition to the one required for the insertion of the nail. So I think you can pick your patients more. I think you have to pick your patients carefully. This system works and it's low tech and you don't need a nail.
Thank you.
Dwayne, just to clarify your technique, you do just small stab incisions for the screws that you put in, or do you do like minimal approaches to try to elevate the joint surface? Like how do you do it exactly?
Well, we use as one of our other faculty presented approaches, and I encourage you all to watch that video. It's an excellent video on approach. We use those principles. And so if you have joint incongruity, approach it with the best approach. I think it's probably best to avoid a posterior approach if you can. And in my video that's posted on the pre-conference video, you can use traction and knee extension to try to elevate posterior fragments. You can use anterior to posterior screws for those. And so I think that you have to experiment and learn from these situations, but you do what's necessary to get a good articular surface reduction, taking in consideration your patient's physiologic condition, obesity, etc.
The only challenge here is you need C-arm, right? You need fluoroscopy.
You have to have C-arm.
Yeah.
But you don't need much else other than the screws, a drill, K-wires, and a traction pin.
And you're generally putting your traction pin as it shows in that film there in the sort of distal third of the tibia?
No, I put it 3 finger breadths above, 2 or 3 finger breadths above the ankle joint. It's metaphyseal bone.
Yep.
If you look at my video, it shows you the anatomy, and this is higher than I would advise. So
That's
you
a
want
great approach. This is a really, this is a fantastic, when you look at that post-op day 1 film, you think, wow, we've got some problems with that tibial tubercle there anteriorly, and that may not heal just, from the quad pulling on it and your tibial shaft not being, correctly aligned right at that tibial tubercle, right? You can see that on that lateral, but the effect of the traction over the several weeks that you kept the patient in traction, allowed that to correct, and you got a nice callus formation and it healed in beautifully.
The other advantage the traction has is you don't get flexion contractures.
Right, because you're keeping them in extension, right? So they're not going to wind up stuck out in flexion. That's a really interesting case. And it's what you've really done here is turn this from a C-type fracture where you have bad articular involvement into an A-type fracture where now you're, instead of dealing with a complex articular injury, you're dealing with a metaphyseal injury at the level of the tibial tubercle. And, for those of us who are doing, limb lengthening, that's really where you want to make your osteotomy, because you get such robust, activity at the bone and that sort of metaphyseal diaphyseal junction in the proximal third of the tibia. And in this case, by locking your articular surface back together with your lag screws, you've turned this, from a C-type fracture into an A-type fracture. And now it's just a question of getting the metaphysis to consolidate, which it will do quite readily. This is a really, very clever approach.
To that point about converting a C-type fracture to an A-type fracture, I'd like maybe to ask Dr. Naresh Agarwal to comment about his method of doing very similar percutaneous fixation around the joint and then the intramedullary nail rather than traction. Naresh, please.
Yes, thank you, Kiran, and thank you, Dr. Anderson, for appreciating the talk. But it is an excellent case, managed excellently. This is very close to our philosophy of management. Only thing I can comment about here is that out of the 4 screws on the lateral side, lateral to medial, one at least could have gone from medial to lateral, and that would have avoided another stab, one stab incision on the lateral side. And then the condylar fragment is not very well adequately stabilized on the diaphyseal fragment, and so we had to keep it in traction for a long time. Now, to stabilize the condylar fragment on the diaphyseal fragment, the main shaft, nail is one option that we use very regularly, and the other option could be that we put 2 K wires, cross K wires, relatively thicker K wires from the ends of the each condyle, and then go right about 2 to 3 inches below the main in 2 to 3 inches into the diaphysis, which is not fractured on each side, and it becomes a cross, and that would allow us to shorten the duration of traction and allow better mobilization of the knee. So this is the only thing I would say. Otherwise, wonderfully managed. It is in terms of investment, it is a low risk, high return investment.
Thanks, Naresh. And sorry, Shravya, to butt in here, but there was one other. I wanted to see if Pierre-Marie Woolley is on the line still, or if any of the other faculty can comment a little bit on the use of hybrid external fixation. I've seen a few cases shared with by colleagues from Haiti, which, as many of you will know, is going through a very difficult time, and they don't have access to implants, very limited implants. So what they're doing is they're putting sort of these rafting K-wires and then attaching it, to pins into the tibial shaft with a hybrid external fixator construct. I've seen a few cases coming out of the Pacific Islands that look like that as well. Allows early range of motion, just as Dwayne has done here with his skeletal traction. I'm curious if anybody has any experience doing that. Dankward, you've given a thumbs up. Do you have any experience doing hybrid fixation?
Yes, I have these experiences, and this works very well. You can make traction with this system, and you can do exercises very early, even with external fixation. With 2 or 3 crosswise pins and a ring, and then make a hybrid fixation to the shaft.
Thanks, Dankward. And I think I see a comment from Dr. Nicholas Lubega asking a very similar question about using circular frame kind of thing for maintaining alignment and length. Jack, you raised your hand, and I was going to ask you to comment because you brought up the very important issue of pins being in the joint capsule and those potentially raising the risk of infection. So I don't know if that's what you wanted to comment on, but I wanted you to say something about it.
Yeah, perhaps Dr. Swinkowski and I can comment on this. I remember back in the day when we did this, routinely back in the late 90s, where, hybrid, these Monticelli, Spinelli, Hoffman hybrid was just like a mouthful of words you could throw out, which was awesome. So we did a bunch of these cases, and the soft tissue management is difficult. Theoretically, it's similar to what we're seeing here, right? You're fixing the metaphysis, you're trying to turn, a C-type into an A-type, and then you span that diaphyseal metaphyseal junction with the skinny wires up top and standard half pins down below. But the soft tissue complications are difficult, and those frames are hard to take care of. And the skinny wires, even though they're tensioned, can easily get loose in the proximal metaphysis. You can't run those wires within 1 centimeter or 2 of the joint line, or you will get a joint infection. And, this is a bad problem, but this problem on top of septic arthritis is also a bad problem. So my take would be to say to people, if you have no other option, I think hybrid's probably, something you might want to consider. If you're in a situation where you have access to C-arm and lag screws, this looks like a great technique, and I would do this over a hybrid external fixator for infection risk reasons.
We do this about 90% of our cases.
Yeah, I mean, this is
We
a
do
really
not
nice way to
use-
go. Yeah, I'm sure your soft tissue complication rate's quite low, particularly relative to what you would expect with a hybrid external fixator. Those pins, the skinny wire pins, are not well tolerated by patients. They get infected fairly readily.
We also think that fixators prevent at least Ethiopians from moving their knee. And it's just too much work. And one traction pin through the ankle seems like too easy, but it works.
And you keep them in that traction, like in full-time traction, for how long?
3 weeks.
3 weeks. Yeah.
Take it off.
So they're tied to the bed, and you have to just keep pulling them back up to the top of the bed. And what kind of weight are you typically putting on the traction?
Well, we try to get X-rays in traction, and we start out with, as Ipsa said, maybe 1/10 of the body weight, but we try to manage it by sending it to X-ray with them in traction and seeing if it's enough or not enough.
Gotcha.
So we start range of motion. Ipsa didn't include a photo of the patient in traction, but they put their hands behind their knee, pull up the knee while in traction, and so it keeps the joint reaction forces to minimal. So you don't have collapse of the articular surface, and it's well tolerated. They don't have pins coming out of their legs saying, I can't move my knee, I can't move my knee, I got these pins. And it works.
Well, you run into that with the skinny wires. Patients really, as you move the leg, the skinny wires really limit people's motion, and they can have a lot of pain around the proximal tibia with the skinny wires. So, even in the limb lengthening cases that we're doing, or using, spatial frames for deformity correction, we try and use as many half pins as we can and get away from the skinny wires.
I have about 6 more patients to put on my PowerPoint, but I've got 30 patients, probably 6 of them with plates and the rest of them with this method. And I will send that out to this group when I'm finished with it, hopefully later today.
We would be honored to upload it for the network, Dwayne. Thank you for that. Last comment from the chat was, what kind of screws are these? I assume these are just like 4 or 5 large frags. Is that right?
Most of those are 6.5s.
6.5s.
It's a combo.
Cool.
Ipsa was there, so he would know.
It was 6.5.
Well, I think all 3 cases that we've discussed so far have shown us something different about how complex tibial plateau fracture management can be. Do the faculty have any final comments on these injuries and, sort of tips and tricks or advice that you've picked up over the years in managing these injuries?
I find the easiest way to take care of them is to transfer them to Dr. Rodriguez. That's usually my approach to the really complicated ones.
At which point I say keep it for Tuesday, so Dr. Wicksted does it. So I think answering your question, there are some priorities that I go over, right? Obviously we have to restore length, restore alignment, but if your soft tissues are not going to work out, then everything's going to fail. So soft tissues is probably management of the soft tissues is one of your most important priorities, right? Particularly if you happen to be in a setting where your salvage options may be limited. Either you don't have access to a microvascular flap reconstruction or something like that. You really have to prioritize protecting your soft tissues. Then your alignment, then your joint, and do whatever intervention you do in a measured way, keeping in mind what you need to preserve and what you can salvage and not. That's worked for me for many years.
I would say also, just as a final closing comment, I recognize that in resource poor settings where patients are paying out of pocket for some of these surgeries, that having 2 surgeries is a burden. But I would also say that having an infected plateau is a bigger burden. So, doing these things in stages is completely fine. You can get the medial side, you know, as Dr. Swinkowski pointed out, the medial side is usually pretty solid, and you can restore your alignment by putting a plate on the medial side and letting everything settle. And then you can, you know, you've got 2 or 3 week window on this, right? We've all said we keep these patients non-weight bearing for 3 months. So there's not a particular rush to getting that lateral side. And if you get the medial side nicely lined up, oftentimes the medial plate alone is enough. You've turned this from a bicondylar into a simple lateral plateau and maintain good alignment, and you can let your soft tissue settle down. And just to save yourself some soft tissue complications, staging these can be a helpful technique. Thank you.
And my comment is that these cases have really shown us that the degree of comminution is so often related to the bone quality, and the higher the degree of comminution usually means bad bone quality, which should direct us all to try as limited approach as possible and avoid extensive plating.
Thank you so much. Dr. Saneja, this is not something that we've discussed in this chat so far, but as we close, can you comment on the further worsening of the soft tissue envelope, either by a vascular injury or compartment syndrome in these injuries, and how that kind of affects your practice?
I think that comes back to Dr. Kairat's point that soft tissue management actually is key. And majority of times we plan on delaying these fixations, also just wondering how the soft tissues will react or staging them. In one of the cases, we were talking about addressing one side first and then waiting to see how the soft tissue envelope reacts and then fixing the other side. But again, in compartment syndrome, same way, or open fracture, same way. I'm wondering first how the soft tissues will be managed before trying to figure out my fixation plan for these. But limited fixation, as some of the cases showed, wonderful limited fixation, trying to respect the soft tissues might be the best bet.
Thank you. I think one very important point, like we all think about plateau fractures as these articular injuries and the importance of restoring the articular surface. But time and again, the faculty today have pointed out how alignment and soft tissue is so much more important than getting the articular surface right. Honestly, you guys have sort of put that at the bottom of your priorities for these fractures, and that was just really interesting for me to hear. Any other final comments?
Wonderful session.
Kieran, anything else from you?
No further comments from me. I think all the faculty have really shared some great points today. I look forward to listening to this again, especially next time I have to do a tibial plateau fracture. I don't know if the patients here in Boston would be as amenable to staying in the hospital for 3 weeks on traction as they are in Soto Christian Hospital, but definitely some important points here and principles that I will apply to my clinical practice. So thank you so much to the faculty. In our last minute here, I'll just close out if that's okay, Shravya. Thank you everybody for joining today. Thanks to the presenters, Dominic, Salem, and EBSA. Thanks for your great presentations today. And thanks to all the faculty again for your comments. If you scan this little QR code or click on the link that was just shared in the chat, you will be able to complete our post-session survey. Thanks very much for sharing that in the chat again. Everybody who completes the pre and post-session surveys for each one of these live sessions, all 4 live sessions, will receive a certificate of participation just as a form of thank you from us at HGOC and SONA for contributing to these events. Let's also continue the conversation. We have a very vibrant community of surgeons and trainees from all around the world on our WhatsApp channel. If you enjoyed the cases and you enjoyed the advice that you got, many of the faculty who contributed today are very active on our community, sharing feedback and giving advice and comments and teaching cases. So please do feel free to join our community and continue the conversation. Also, we recently launched our SONA Global Academy website, which has all of the curriculum, including fantastic free resources shared by Ostgenic, JOMI, Ortho Evidence, and OTA. That are curated and organized by topic. And of course, not to mention all the excellent lectures contributed by the faculty members available in English, Spanish, and French for you to go through. So please do share with your community. Please join us as we continue to learn together. Thank you so much for joining. I'll leave this slide up with the links to the surveys, and I'll leave the line open for a few more minutes as we close out here. Thank you so much, everybody. Have a wonderful rest of your day.